All right, let's get started. Good morning and welcome to Take 10, Transforming Care for Women with Substance Use Disorders and Their Families. And we're going to be looking at intersections of SUDs and trauma with Gabriela Zapata Alma. This presentation is brought to you by the Great Lakes ATTC, and we're funded through SAMHSA under the following cooperative agreements. The I got stuck. This presentation was prepared for us, and the comments are those of the speaker and do not represent the official position of SAMHSA. The use of affirming language inspires hope and advances recovery, and the ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. Just a few housekeeping items. If you have technical issues, please individually message, and it says Alyssa Kuala, but please individually message me, Rebecca Buller. I'm covering for her today at the bottom of your screen, and I will be happy to assist you. If you have questions for the speaker, please put those in the Q&A section at the toolbar at the bottom of your screen, and we will do our best to get to those either throughout or at the end. And the recording and the slides will be made available on our website by the end of the week. If captions or live transcript would be helpful, please locate the option using your Zoom toolbar, again at the bottom of your screen. You will be directed to a short survey at the end of today's presentation, and we would really appreciate it if you could fill it out. It takes about 3 minutes, and it helps us report to our funders and improve our offerings. And certificates of attendance will be sent out via email to all who attended today's sessions in full. Please join us on social media. And now I want to turn things over to Gabriela Zapata Alma, and she is the director of the National Center on Domestic Violence, Trauma, and Mental Health, as well as a lecturer at the University of Chicago, where they direct the Alcohol and Other Drug Counselor Training Program within the Crown Family School of Social Work, Policy, and Practice. Thanks for being with us.
My pleasure. Thank you so much for having me. And I already put in the chat just a big hello and welcome to everyone. We're so glad that you're here with us today. And if you could take a moment and introduce yourself in the chat, I know that so often a huge part of these sessions is also being able to connect with each other. And so we'd love to hear from folks, and we'd love for folks to feel free to use the chat to connect with one another. And so I am super excited to offer this brief talk on the intersections of substance use disorders and trauma. And so, in case you're not familiar with the National Center on Domestic Violence, Trauma, and Mental Health, there's just a little bit of information about the center that I help lead here in the slide, which I'm sure will be made available. We are headquartered in Chicago, and so we're part of the Great Lakes region. And we're headquartered here in the traditional homelands of the Council of the Three Fires, the Odawa, the Ojibwe, and the Potawatomi. Chicago continues to be home to a lot of people who are traditionally part of this land and who continue to practice their traditional culture, including care for the land and the waterways. We are blessed to have actually the third largest population of Indigenous people living in an urban environment, alongside many diverse communities. And so here for this session, we're gonna just introduce some of the emotional, physical, and socioeconomic factors that uniquely impact women during treatment, especially how these factors relate to the intersections of substance use disorders and trauma. And so first, in order to understand the intersection of SUD and trauma, it's essential that we also understand that the opposite of addiction is not the mere absence of a substance use disorder, but that it is one of connection, right? And so regardless of the current state of the substance use disorder, anytime that we are able to really help people to build those connections within themselves, connection with our program team and environment, and connection in the broader community with their family members, their friends, their neighbors, right? Employment, peer-based support, that really this is something that really crosses all those different pathways of recovery. And so knowing that, for example, 75% of people with a diagnosable substance use disorder are also experiencing the effects of trauma, right? So that's 3/4 of people with a diagnosable substance use disorder. And that's just people in the community living their day-to-day lives. Now, when we look specifically at people in treatment at this time, that number jumps up to 95%. So virtually everyone, almost everyone who we are seeing in substance use disorder care is experiencing the effects of trauma in one way or another. And we'll talk a little more about this in March when we come back together for that March session. But a lot of times for people in treatment, the trauma is not something that happened in the past, but the trauma is something that is ongoing, that they're continuing to deal with in the here and now. And so then zeroing in specifically on women's trauma and substance use disorder, we know that there are very high rates of trauma amongst women with substance use disorder. And then there's also research that suggests that the higher trauma severity is correlated with a higher substance use disorder severity. So, as you all know, who are responsible for diagnosing substance use disorder, that in the DSM-5, we also diagnose severity, mild, moderate, severe. And so that as people's severity of their trauma experiences increases, we find that also the severity of the substance use disorder matches that. And in this way, the trauma and the substance use can then create what sometimes is referred to as a vicious cycle, where we know that women who experience victimization have a much higher risk, a 6 times higher risk of developing a diagnosable substance use disorder. And at the same time, when women use substances, whether or not it's a diagnosable substance use disorder, they also tend to experience increased targeting, meaning increased targeting for victimization. Now, it's really important that we're clear here that it's not that women using substances somehow magically produces a higher trauma exposure or a higher rate of victimization. That it is people who choose to use violence, people who choose to victimize and target women, in fact, are then trying to take advantage of a woman using substances to then target them for victimization. And one of the reasons that this happens is because of the stigma related to substance use and substance use disorders. Particularly women who use substances face much higher stigma than their male counterparts. And so here, it's important to remember that violence is not something accidental, that we just kind of trip and fall into violence, but that victimization and the use of violence is a choice that a person makes, and that what we do know about violence is that it flows towards people with higher levels of stigma and with less power, right? And so this is how we see what is sometimes called that vicious cycle between substance use and trauma show up, particularly for women. And so we know that trauma many times is just not, it's not something that just happened this one time and now it's over, right? That many times trauma can be complex, meaning that there can be many different kinds of threats to our safety, and that trauma can also be chronic, meaning that it is repetitive, it is happening over time. And so, in this way, we know very often that trauma has a cumulative effect, that it's not just this one thing happened and then we're trying to get support around dealing with that trauma, and then another thing happened and then we're trying to get support about that not that next thing, right? It's not just like a one thing, one thing, one thing, but that a lot of this actually has it exponentially creates larger effects of trauma that then can impact many areas of a woman's life and the life of her children if she has children. And that these effects can be over a lot of different parts of a person's experience, and that it can have lasting effects. And so this diagram here is from the CDC, and it's looking specifically at adverse childhood experiences and really just looking at those original ACEs that occurred under age 18 within the household, right? As opposed to what we know now about community level ACEs and other forms of ACEs. So, just looking at those ACEs within the household, we can see that those early adverse experiences of physical abuse, sexual abuse, having a parent who's treated violently, having parental separation, right? Things like that. Neglect, of course, cannot forget neglect. And there are many more that I'm not naming here. I'm kind of relying a little bit on ACEs being a little more common knowledge today than it was maybe 10 years ago. And so we see here that even just looking at those traditional ACEs, that they can be correlated with adverse effects across the lifespan and across many different areas of life. So we see here, for example, maternal health. We see here alcohol and substance use. We see also cancer, diabetes, education, access to income, reproductive health and infectious disease, as well as injury, traumatic brain injury, fractures, burns. And something I'll name here about injury is that experiences of ACEs are also correlated with experiences of being victimized by an intimate partner violence, particularly physical and sexual assault. And then mental health, depression, anxiety, suicide, PTSD. And so while this diagram makes it look like it's this kind of like unique pathways or unique spokes, what the reality is that many of the women that we are serving who are experiencing the intersection of a diagnosable substance use disorder and the effects of trauma very often are experiencing many of these different adverse effects, and that's something that we know from ACEs too, that the effects of having more ACEs tend to compound, right? The effects tend to be stronger. The risks tend to go up more rapidly, right? Now, at the same time, it's incredibly important that we don't take this information and have a fatalistic view of it. It's incredibly important that we understand that people also have protective childhood experiences, that people have protective factors that help mitigate these risk factors and these adverse childhood experiences. And that in all of this, that we never forget that people have unique strengths, individual strengths, family strengths, community and cultural strengths, that people have strengths with which that has helped them to come to this moment, and that we want to be sure that we are affirming and highlighting those strengths and really building on those strengths while helping to strengthen those protective factors and never taking a kind of fatalistic view of a person, their situation, or what they've been through, right? What a person has been through does not define them. What it does is help us understand what might be some of the unique barriers and challenges and services that we may need to offer. And so, as we think about those unique experiences, needs, barriers, and gaps, here, just thinking really broadly around the three core areas that we named in the description. And I want to invite everyone to put in the chat as well different things that are coming to mind for you as we go through these different pieces. So, thinking about the emotional domain, right? So we know that particularly for women, and of course, we don't want to homogenize women. We want to understand that women also, like any group, there are a lot of differences, there are a lot of unique experiences, and that a woman's experience is very often also shaped by the other social identities that she experiences. Um, and so, but so thinking kind of broad trends here around some of the emotional experiences. There is research to indicate that, when I say research, there's decades of research to indicate that relational approaches are incredibly important, and that women tend to feel a lot more safe, cared for, connected, and have a lot better outcomes in treatment, including engagement, retention, completion, and recovery outcomes when our services are relational. So, what that looks like is that a person feels like they are cared for as an individual, as a member of a family, that they are cared for, that they're not just treated like another number or another case, um, and that there is a sense of the staff really respecting them as a person and connecting with them on that relational, emotional level. What comes to mind for me often is you don't have a client until you have a relationship. And that is true from my perspective for everyone, but particularly for women, this is going to be true, as well as some other groups as well. Um, and so also here, remembering that women are much more likely to come to treatment with experiences of relational trauma. So much more likely to have experienced domestic violence, sexual violence, human trafficking, abuse as a child is a huge risk factor, a huge gender specific risk factor for women when it comes to substance use disorders, as well as the experience of being a parentified child is also a gender specific risk factor for women. And so we may be meeting women who are wearing a million different hats and having to take care of everyone and everything in their lives. And treatment may be one of the few places where we're able to actually offer support and resources for them, right? That they're not having to take care of yet somebody else. And so, in that way, it's also important that the resources and the support that we provide isn't just for the woman, but also for anyone else who may be in her family as she defines it. Because to help a woman is also to help her in all the hats that she is wearing, and all the different people who are relying on her and are connected to her. And so, something else I'll name here about the emotional around common barriers and gaps is that if a woman comes to treatment and isn't seeing other women and other women there, or doesn't have the option to connect with a woman counselor should she decide she needs that, that can absolutely be a barrier for women. And what we've seen, and we're going to talk in more depth about next month, is that having women counselors available while also ensuring that women have the choice of whether or not they're engaging with a woman counselor or a counselor of another gender, that when women have access to women's groups in the treatment program, even if they don't attend the women's group, the very fact that they have access to that improves their engagement and retention and completion and recovery outcomes, right? Because we know all of those outcomes are related. Um, and that something else that has been found is that peer-based support is especially important for women. And so finding that many women who otherwise would have fallen out of care, right? That when they were engaged with peer-based support, with peer-run and peer-facilitated women's groups, that then their engagement and retention outcomes were much, much better, which then, of course, led to those completion and recovery outcomes improving as well. And that integrated treatment for trauma and substance use disorder is going to be really essential here, is going to be the standard of care. And thankfully, we have decades of research on this point of very accessible and evidence-based integrated treatment programs that can be done in groups and individual, etc., as well as parent-child programs. Um, and that being able to have access to resources around supporting psychological and emotional and mental health in an integrated way with the substance use disorder care is going to be really essential. Now, looking at the physical, we know that women are much more likely to experience the physical adverse effects of substance use, even when using smaller amounts of substances for shorter amounts of time. That includes cardiovascular health, risk for overdose and needing to go to emergency medical care and hospitalization. So, all kinds of different physical health adverse outcomes and needs related to using smaller amounts of substances for shorter amounts of time. We also know that the impact of trauma also has an impact on our physical health. That as cortisol levels and chronic stress is experienced physically, that is also impacts our inflammation. And that inflammation is associated with all kinds of different physical health conditions, from diabetes, cardiovascular, of course, which I already named, as well as gastrointestinal conditions and autoimmune conditions. Women are also more likely to experience co-occurring disordered eating, and so which we could put in the physical as well as emotional domain. And so here again, really pointing to the need for holistic care, for integrated services. And if we aren't able to integrate some of those physical health services, at the very least, having the services where we are talking with women around their physical health needs and then connecting them to trusted community-based providers who we know will work with the women that we're serving in ways that are effective, respectful, and are accessible for them. Again, thinking about the increased stigma that women face. And here, of course, also the perinatal care, of course, as well, and just reproductive health care in general. And then the socioeconomic domain. We know that women, by the time they reach treatment, are much more likely to have low or no income while also having children in their care. So having really low resource access while at the same time having higher resource needs. And we can see how this reality then plays out as creating barriers to treatment, right? Especially where women are wearing so many different hats and feeling like, how in the world can I go to treatment when I need to make sure we have food on the table? Or, you know, sometimes coming to treatment and saying, my number one goal is income. And we, as treatment providers, we need to be able to hear that and integrate those vocational needs in the ways that we are supporting women and the kinds of services that we're offering either in-house or through a community-based referral with a trusted resource. Because if we tell somebody who is struggling to, keep a roof over their head and feed their children or feed themselves, that they have to, work on their recovery before they can work on their income, then we're setting up a barrier. right? We have to really, and this is a part of person-centered care. This is why we ask people, what are your goals, right? What would have to happen together for you to consider treatment a success, right? What are your goals? And then what are the priorities? How do you rank the different goals? So when people are coming to us and saying, I need an income, right? That's for us to hear that and work with them on that, and not to be telling them that they somehow need something else before they need an income. And so the socioeconomic piece can be really incredibly difficult and critical for a lot of the women who are attempting to access our services. And so here we often think about different referral relationships that we need in our substance use disorder care settings. And very often people don't, the vocational resources aren't at the top of the list. But for many people coming to our services, the vocational resources and the economic resources are going to be at the top of their list. And so we want to make sure that we are prepared to respond to that unique reality and offer those resources. So, with that, I want to say please, please, please join us in March. This was just a little taste. And in March, we have a full 2 hours together. We're going to be really getting into a lot of the who, what, where, when, how of a lot of the things that we talked about today. And so we have the registration here in the chat. And then we have a few minutes for questions. So I want to make sure just to offer, well, first of all, offer my gratitude and my thanks for everything that you are doing to care for people experiencing trauma, experiencing substance use, and helping people to, supporting them to be able to build that life that they want, that they need, as they see it for themselves, knowing that they're the expert on their own experience. Here's my contact information. Feel free to reach out. And then we also have a bunch of different free resources on our website. We have this guide on supporting survivors of domestic violence who are using substances, as well as just a lot of other different resources. But with that, you'll get a copy of the slides and you'll get a sense of what some of these resources are. And I want to make sure that we open it up for question and answer. So I'm going to pull the slides down just so we can see one another, or so we can see ourselves. And just opening the floor for any questions.
I'm not seeing any in the Q&A or in the chat. You could use either at this point. We're so close to the end, just a minute left.
Hmm. Well,
Well,
thank you. Oh, go ahead.
no, I was just going to say same thing. Thank you to you for being here today. And we will follow up with email and slides and information on how to see the recording and information to sign up for March.
Thank you so much, everyone, and looking forward to being together in March.